Physician Focus. I'm Dr. Bruce Karlin. Obesity in America continues to be a major public health problem, with some 36% of adults and 17% of children and adolescents considered obese, according to statistics from the U.S. Centers for Disease Control and Prevention. Along with this epidemic of obesity has come an increasing patient demand for weight loss surgery, with about 220,000 operations now taking place each year. Weight loss surgery is known to be an effective treatment for excessive weight, and increasing evidence suggests it might also be effective therapy for metabolic diseases such as diabetes and hypertension. This edition of Physician Focus will take a close look at this surgery, examining such questions as who is eligible for this treatment, what is required of patients, what are the risks of this kind of surgery, and how successful is it as a treatment for obesity. With me for this discussion are Dr. Mitchell Gitkind and Dr. Rick Buckley. Dr. Gitkind is a board-certified internist and medical director of the UMass Memorial Weight Center in Worcester. And Dr. Buckley is a board-certified general surgeon and former director of the Bariatric Surgery Center at North Shore Medical Center in Salem. Welcome to you both.
Thank you, Bruce.
Thank you.
Let's just jump right into it. So we've got this big epidemic throughout the country of obesity. Who among these patients is eligible? Do you want to take that one, Rick?
Sure. There are criteria that the National Institute of Health set up back in 1991, which actually haven't changed, and they go by BMI, which is a rough guesstimate of people's weight.
What does BMI stand for?
BMI stands for Body Mass Index, and technically, if your BMI is 30, you're considered obese.
So the higher the number, the bigger you are.
Yes, and the worse the impact on your life. Candidates for the operation are in BMIs in the 35 and above range currently. Over 40, which is roughly 100 pounds overweight, would be a BMI of 40 or above. BMI 50 is 150 pounds or more overweight, and a BMI of 35 to 39 is usually around 80 pounds overweight. And then there are different criteria within those categories that make somebody a surgical candidate.
So your mortality risk is related to this?
Yes.
You brought us a lovely...
As your weight or BMI goes up, your mortality goes up also. So someone with a BMI of 40 on average dies 10 years sooner than the same age person with the same morbidity, but who's in a normal range BMI down in the 20-25 range. So as we get into the various operations in the discussion tonight, what we're trying to do is bring people's BMI back down to a safe range. It's not all about losing pounds, it's about losing BMI points.
So getting it down. So the weight or the BMI, which is weight per height, is the main medical characteristic. What else goes into this? Mitch, you do a lot of work. I love your work out in Worcester.
Thank you.
Where your clinic spends a lot of time looking at psychological characteristics.
Right. So we start with with more of the mathematical criteria that Rick has already described, because from the National Institutes of Health and the medical recommendation, and also where our partners in insurance will cover these types of surgeries, all relate to the NIH criteria that Rick has already reviewed. So that's sort of the initial kind of cut, if you will, from the adult population with obesity.
This isn't just about who covers it. It turns out that coverage is quite reasonable, and that it's a very supportable coverage.
Right. So that's a great point to make, is that the vast majority of people, especially in Massachusetts, have health insurance, and have health insurance that does cover this type of surgery, assuming that people meet those mathematical criteria as Rick has described them. At that point, once people sort of get through that determination, comes the hard work that you were referring to, which is really helping people understand the type of work that needs to get done to put them in position to succeed with the surgeries long term. And that's where a multidisciplinary team like what we have at UMass, and I know that Rick had worked with at North Shore, that includes the medical, the physicians, the internists, dietitians, psychologists. We have an exercise physiologist at UMass Memorial, probably your patients have worked with. And so it's really bringing patients through a preparation process that improves their approach to eating, improves their physical activity level, hopefully, and just kind of, I tell patients, builds this foundation that we can put the surgery on top of and expect a really great long-term result.
The long-term result, I think, is what you guys really focus on, and I think that a lot of the good programs do exactly that. My understanding, and certainly from having worked in the Worcester area, is that the weight loss surgery, the bariatric surgery, is sort of to give you a jump start in getting the right diet for a long term, so that you don't just sort of undo the effects of the surgery. Am I off base on that?
No, the operation is a tool, and it's one of many of the tools in the bag that we use to get people healthier. A lot of these folks have diabetes, they have hypertension, they have sleep apnea, they have joint disorders from the carrying around all that extra weight. What we often will tell folks is fill a bucket full of sand and carry that around for a couple hours and see what's happening when you actually realize how much extra weight you're carrying around on yourself. So the operation is one tool, but it's a multi-focused approach to weight loss. The operation can help, but you still have to modify your behavior, get into exercise, get into eating the right things, working with the dietitians, and it's a lifelong process. It's not a quick fix, and it never has been a quick fix.
So I think probably Rick and I tell our post-op patients the same thing, and I also like to encourage our patients to talk to people who have been through the surgery, especially ones that are 2, 3, 5, 10 years, down the road, which is that the surgery is good at helping people stay on track with dietary changes that they're making going into it. And if you talk to groups of people who are more than 2 or 3 years out, what typically they will say is every month, every year that goes by, they're feeling less and less feedback from the surgery. So people you talk to who are 6 months out from surgery that feel less appetite, fuller quicker, they feel like eating less frequently, they have different intolerances to different foods that maybe were problems for them before. As the years go by, appetite increases, ability to eat a little bit more and a little bit more frequently increases. So that's the point at which patients really have to dig in order to get these great long-term results. And that's why I always, and I know Rick does too, encourage people, and you encourage your patients, stick with the center. Go to your dietitian, talk to your support there, because as Rick has already alluded to, this is a lifelong process, even after the surgery.
And the surgery does give you a big jump start on this.
Yes, yeah. Any of the 3 operations that are commonly done give you the jump start. Some are a little bit slower jump start than others, but they all start the process off, and you just can't eat the volume that you used to before. And so the operations are all combinations of restrictive, meaning you can't eat as much, and then with the bypass operation, it's also somewhat malabsorptive, meaning the food that you do eat, you don't absorb all those calories because the digestive enzymes don't join till further downstream where the hookup is done. So that's a combination of restriction and malabsorption.
So let's put it in what can weight loss surgery do, what can't it do?
You will lose weight, and how much weight you will lose we can't predict. It varies with operation, it varies with the patient's ability to exercise beforehand, and it also works with the ability for them to follow up with their exercise routine. Some operations require much more exercise than other operations. So somebody who might be disabled or have joint disorders can't really exercise. You might recommend a different operation for that person than you would for somebody else who has no problems, just has weight as an issue. So you would expect everyone to lose weight. How much, again, is variable.
I think it's a great question, what it can do, what it can't do. I find myself a lot of times telling patients what it can do is help a person who can do pretty well with a dieting and exercise approach. It can help that person, rather than getting a pretty good result from that pretty good effort, it can help people get a much, much better result, a fantastic result, and a result that is much more permanent than what they would get much more durable than what they would just get with just the lifestyle changes alone.
What do you, now the success ratios vary, and I suspect that a lot of it has to do with a lot of the early work that you do in the psychological work and the personality traits that you look for before you do the surgery. And I know both of your programs are very good at doing this. What is your success rate, and how does it compare, say, across the country?
Right. So there is quite a bit of data. I can't quote specifically data from our center, or I would be hesitant to quote data because the data from much, much larger groups and much more long-term is so much more provocative. The data that we have and the information we have from, for example, Swedish obesity study, these are huge cohorts of people who have had weight loss surgery being followed over long periods of time. The reason this very good data comes from Sweden is that they have a national medical record, and so they're able to follow patients long-term, which frankly is one of the big challenges with following even as careful as we are in our patient population, is just keeping patients in follow-up. It's a real challenge. If you look at these large cohorts, though, it's fair to say that about 2/3 of patients, this is usually what we say, I think, and Rick hopefully will agree with this, keep off about 2/3 of their excess body weight at 10 years and beyond. So for a patient like Rick talked about with a body mass index of 40, who's about 100 pounds overweight, we would expect that person reasonably to be able to keep off 70, 80 pounds of that weight long term. Now, everything you're saying, though, Bruce, of course, is absolutely true, which is it's all contingent on sticking with those lifestyle changes. And I would suggest, and Rick would too, I'm sure, that means staying connected to your providers. But we're very impressed with the results. We have data now about life expectancy improvements. We have data about cancer rates decreasing, certainly diabetes, cardiovascular stroke, and heart attack risk. It's all very, very solid.
Right. It's been very impressive with the diabetic population, especially the earlier you get to the type 2 diabetic with the operation, the better the success of curing them or significantly decreasing getting off the medicines. But with all the different comorbidities they have, the sleep apnea, getting off their machines within a year, which makes life around the house, I'm sure, much easier, they tell us. The joints are better. They may not need the replacement surgery that they were looking towards. And if they do, it's much safer. So there's tremendous benefits. And if they stick with it, all the programs are the same, they have good long-term data showing that the people do well, and most 75% keep most of their weight off. It varies again from operation to operation, which we'll get into in a moment.
Well,
why don't we do it now?
Okay. What are the options? Why don't we go through them?
There are 3 common operations that we do, and we recommend them for various reasons. We might favor one over another depending on what prior operation somebody has had, or how healthy they are, and how much they can exercise. The adjustable gastric band is a device, it's a silicone device, so there's no allergy problem, that's put around the top of the stomach. With all the operations, we're trying to restrict how much somebody can eat. So we try to make a pouch that they can eat about 3 ounces at a time. The adjustable gastric band, why we call it adjustable, underneath the skin there's a little port that we can put a special needle in to inject saline or salt water to tighten the band around the stomach. So when we put these in, we don't tighten it because of the risk of swelling and damage in the stomach, but over a couple of months we tighten it so that they can only eat 3 ounces at a time. So the weight loss with this is slower in the beginning. but you really have to exercise a lot. So if you have joint issues or heart issues and you can't exercise vigorously, you really almost have to become a gym rat for this operation.
But
It's
before
not
you
as
go
successful.
on, I'm just hoping that people understand that's not the bottom of your gullet, that is the top of your stomach that you've got it around.
This is the top of the stomach. This is the esophagus that goes from your mouth to the top of your stomach, and this is all the rest of the stomach. So you put it a couple inches below the connection from the esophagus to the stomach, and then progressively tighten it to make it a small opening so you can't eat that much. And you feel full.
All right, well, that's item one.
So then, and I'm going in progression of difficulty of operation.
Okay.
And slightly increased risk, although they're all actually quite safe and very low risk. So the sleeve gastrectomy is the newer operation that's been around for about 8 years now, and most insurers cover it. And you physically remove about 2/3 of the stomach. So you have this long sleeve along the inside of the stomach. Some people call it the banana operation because it almost looks like a banana as it comes around. In the lower 2.5 inches or so of the stomach you leave alone. That's the pumping mechanism to empty the food out of your stomach to go downstream. So there's no bypass involved. It's a purely restrictive operation. This part of the stomach you take out of the body. This makes about 2/3 of our appetite stimulating hormone called ghrelin. So the theory of how this works is you remove the ghrelin, the appetite stimulator, and you've got a long, narrow pouch, so you can't eat that much.
Now, are you having differential success with these differential operations? And are we moving up the chain to the each one getting you closer to that 2/3 of your excess body mass index?
Basically,
corrected?
yes. The band long term is the least effective. You lose about 50% of your weight at 5 years, whereas the sleeve and the bypass, which would be the last one I show, you can lose that 75% of your excess weight and maintain it. The bypass and the sleeve are actually very close in what they do and in resolving some of the comorbidities such as diabetes.
So is the sleeve gastrectomy troubled by less of the long-term problems than the larger operation, or we can get into that later?
Well, you don't have as much of the vitamin malabsorption with the sleeve because we do not change the small intestine, which absorbs your food.
Okay, let's go on to the last,
so the last and
but not least,
what has been and still called the gold standard. It's been around the longest, since 1980, but it's been changed. Now all of these are done minimally invasively, which means 5 small incisions. The biggest one usually is about 1.5 inches, and then the rest are 1/2 inch or less. So with this, we make a pouch, again, the 3-ounce pouch out of the top of the stomach. We leave the rest of the stomach in place. It just sits there, makes some digestive juices, doesn't cause any harm. And then we take about 4 feet of the small intestine and reroute it to do the so-called bypass. So you can't eat that much, it's restrictive, and then you don't start absorbing calories till we reconnect it down here when the digestive juices from your stomach and your pancreas, which sits in here, join to start dissolving food 4 feet downstream. So this has the best track record for weight loss. It's also the most complicated operation to do because you've got several staple lines and hookups down here and at the pouch at the top.
Well, just in talking about these surgeries, what are you left with? What are the risks of this? I mean, you're doing a major rerouting of things here. What happens to these folks otherwise?
Well, the thing that we, the surgeons, or everyone worries about the first, but technical problems are the things we worry about the most. Will any of your staple or suture lines leak, which can make a patient very, very sick? These usually occur within a couple of days of the operation with the sleeve or with the bypass, because we have staple lines where we've divided the stomach. With the band, you have to be careful that you haven't poked a hole in something that can make somebody very sick, or that you've made the band too tight, so they, even though you haven't added fluid yet, they can't eat or drink anything. And then you might have to take it out and put a bigger band in. So those are some of the biggest, specific to the staple lines, is leakage or stricture. Long term, that's when we rely on our friends like Dr. Gitkind about what are the long-term effects of malabsorption or not getting your proper nutrients.
Mitch, you
Well,
want to
again,
jump in here?
Sure. I think it boils down again to what we talked about, which is sticking with your provider team, maintaining good quality nutritional approach to what patients are doing long term. I mean, it turns out in this day and age, with modern approaches to surgery and with the way that the gastric bypass is done now, where you're not bypassing all that much small intestine, that really serious complicated vitamin deficiencies that are hard to replace with oral supplementation and all are pretty rare. Iron deficiency we certainly do run into, especially in women who are menstruating age females. It's really important that they keep up with iron intake. It's important also, a little bit more so in the female population, to keep up with calcium and vitamin D, but not all that different than in your regular population of people anyway. So I think what we're seeing really in a properly selected sort of population, that the right people are having these surgeries and they are compliant, sort of, as we call it, relative to sticking with the plan afterward. In terms of running into major long-term problems, it's not that common. One thing I would throw out there, because we emphasize this at the orientation, I think it's worth mentioning here for your audience, is about cigarette smoking. And I'm sure Rick has had this talk 10,000 times, and I know I have, which is that patients who are going to have, I really say, and I think Rick would too, any of these surgeries, but particularly bypass, I think the sleeve gastrectomy we can throw in there too, that the incidence of one of the complications that we worry about, which is ulcers, which can bleed, which can perforate, which can require more surgery and create very serious trouble down the line, overwhelmingly where you see that are people who go back to cigarette smoking. So we tell people, if you're serious about weight loss surgery, it's time to start taking great care of your body. And because a lot of times patients will say, what can I start doing right now? And I tell them, if they smoke, I say, now's a great time to really start to work on that. The one other thing I just wanted to go back to, because you asked about results, and we tend to, because we're doctors and scientists, we get hooked into statistics and reasonably so. But some of these stories were popping into my mind as we were reflecting on that, because I had a patient who emailed me a couple days ago to say that since she had her bypass, she was infertile. Since she had her bypass surgery, she's had 2 pregnancies, 2 healthy average risk pregnancies, and 2 healthy kids. I was also reminded of a guy who contacted us recently to talk to our exercise physiologist for advice about what to eat while he was running the Disney Marathon this year. So this is a guy who had a bypass 2 years ago and was running a marathon. So what you hear a lot from patients, yes, they're healthier, yes, they're taking fewer medications, they get rid of their sleep apnea treatment, but a lot of the common denominator, I got my life back. I'm doing things I have never been able to do before, and that's really gratifying.
And I would really stress the smoking cessation. We demand that our patients are smoke-free. We actually test them to make sure they're smoke-free for 3 months before the operation. The ulcers, the chronic pain, the strictures of the operations are so much higher in the smokers. So that's a very, very important point to stress.
And that gets back to some of the work that you do prior to operations, and it's the choice of people to do this. If they can't quit smoking, if they're not going to stick to a diet, perhaps. Is that part of the personality characteristics that you're looking at?
I think there's a lot of overlay there, and I do try to make that point to patients, which is the smoking thing is a good way to challenge yourself to figure out how ready you are to make the changes that will, again, put you in position for long-term success. We also see a lot of patients who are struggling, and we're there to help them with substance abuse issues, maybe alcohol intake that's above average. Those issues come up very frequently.
So after the operation, just quickly, there are a couple of things that go wrong. I understand that my patients can't take as much alcohol as they used to.
Right, especially with the bypass procedure, the alcohol goes right into the small intestine, gets absorbed very quickly. So there is about a 5% risk of becoming an alcoholic because you get the buzz very quickly. So It's more of a problem in the bypass patient, and we all stress it in all the programs ahead of time. They've got to be very, very cautious. We try to have people not drink for a year after the operation.
Well, we're really coming close to the end here, so we're going to have to wrap up very quickly. But do you have some parting thoughts as to things that you want to tell the public about bypass operations? Rick, why don't you take that?
One is that it isn't the simple fix. It's a lot of work, probably more work than they've ever done before. The other, it is a very safe procedure. It's the same degree of risk for most patients as having your gallbladder out, and no one thinks anything about having the gallbladder out. But you have to really commit to a lifelong process.
Quick 10 seconds.
Sure.
Mitch, you got something to add to that?
Right, for patients who this sounds interesting to them, if your doctor's not bringing it up, bring it up with your doctor. There's so much good information out there. Come, at least educate yourself about it and see whether you think it's a fit for you.
Well, thank you both. Dr. Buckley, Dr. Gitkind, this has been a whirlwind tour of bypass operations and gastric surgery for weight loss, and I thank you both. You've been wonderful guests.
Thank you.
Thank you.
For more information about weight loss surgery, visit the websites listed at the end of our show. And to view past physician-focused programs covering a variety of healthcare topics, visit our website at physicianfocus.org. I'm Dr. Bruce Karlin. Thank you for watching.
I'm Dr. Mitch Gitkind.
And I'm Dr. Rick Buckley.
The obesity epidemic has dramatically increased patient demand for weight loss surgery, with some 220,000 operations taking place each year.
Weight loss surgery can be an effective treatment for patients with severe obesity who have trouble losing weight or who suffer from obesity-related problems, such as diabetes.
Having surgery to help you lose weight, however, is a serious decision, and patients must make a commitment to change lifestyle habits and have medical follow-up for the rest of their lives.
If you're thinking of weight loss surgery, discuss this with your physician and family and carefully evaluate the options and risks.
Make sure you're prepared and willing to make the lifelong diet and activity changes needed for a successful outcome.
For more information, visit the American Society for Metabolic and Bariatric Surgery.
I'm Dr. Scott Oliver. More than 1 million Americans a year are getting joint replacements, and as our population ages, this number will increase. While these operations are becoming more common, replacing a hip or a knee is a complex procedure and requires extensive preparation by the patient. So if you're considering this kind of surgery, learn what to expect before, during, and after surgery. Ask what you'll need to prepare for the surgery, including your physical preparation, communicating with your medical team, and planning for your recovery at home. Ask about what kind of anesthesia and implant will be used, how long you'll be in the hospital, what is required for rehabilitation and pain management, and complications that could arise. Joint replacements can relieve pain and allow for a more active life, and preparing properly for the procedure is a key to a successful outcome. For more information, visit the American Academy of Orthopedic Surgery.